Good evening and welcome to our live call-in show from Opelousas from Cardiovascular Institute of South and Heart and Vascular Institute at Opelousas General Hospital. This is our monthly live call-in, second Tuesday of each month. Tonight's topic, we have deep vein thrombosis and pulmonary embolism. We'll elaborate on these subjects. And first of all, I'll introduce my partners here in crime to all the audience. All of you must be familiar with Dr. Hammett, who's one of my interventional colleagues and senior partners at Opelousas General. Dr. Arzola is a non-interventional cardiologist with special interest in echocardiography and non-invasive medicine. And welcome to this show. And tonight we have a huge topic to cover within 1 hour here, and we have an extensive subject of both deep vein thrombosis and pulmonary embolism. And I also want to remind our audience that this is a live call-in show, and the number will be flashing at the bottom of your screen periodically for you all to call in and ask any questions pertaining to this subject or any other cardiovascular question. To start off this topic, and I want to just kind of blurt out some statistics that I usually do. The incidence of deep vein thrombosis and pulmonary embolism are not precisely known, but the range is quite wide. Somewhere about 300 to 600,000 new diagnoses of venous thromboembolism can happen each year. And somewhere about 60 to 100,000 Americans die each year from consequences of venous thromboembolism, be it secondary to deep vein thrombosis, and most likely pulmonary embolism or clots migrating to the lungs would likely be the most common cause of death, but there could be other long-term consequences as well, which we'll talk about. And about 10 to 30% of the people diagnosed with this condition could die within 1 month of the diagnosis, and sudden death could be the very first symptom. Sudden death, unexplained death in the hospital or outside setting can be the very first manifestation of venous thromboembolism. And 1/3 of the people who have had deep vein thrombosis or clots in the leg veins can have long-term complications, and 1/3 of them can have the so-called pulmonary embolism or clots migrating to the lungs, causing pretty deadly consequences, as we'll elaborate later on. Somewhere about 5 to 8% of the population in the United States could be prone and have a genetic predisposition to have a hypercoagulable or high clotting tendency to develop deep vein thrombosis. Without confusing the audience, and I also want to elaborate, we'll be using some of these terms. I want the audience to understand when we say DVT in this discussion, we are referring to clots in the leg veins. When we say PE, it means pulmonary embolism, which again refers to clots migrating to the lungs. And we'll elaborate on these subjects. And Clay, I want you to just kind of make some opening remarks about why, as cardiologists or cardiovascular specialists, we should be involved in treatment or care of deep vein thrombosis. And then we'll kind of elaborate the definitions and as the discussion goes on.
Well, first of all, like you said, we have an hour to dedicate to this, and they usually have conferences that last a week on this one subject. So it's a lot of material in 1 hour, but we'll do our best. Our role, I think our role in DVT is I'm going to take this from the approach of prevention, because I think that's the key here is what we as caregivers and all providers, nurse practitioners, general medicine doctors, surgeons, this is a disease entity that incorporates every field of medicine. No field of medicine is really spared from having patients that can have or are susceptible to having DVT or PE. And the consequences of PE are so dramatic and severe that it is probably, if not the leading cause of in-hospital mortality or death, or at least severe morbidity, that I think we're all significantly aware these days in the prevention. Treatment, I'm going to leave that up to you to discuss a little bit later, but prevention is basically, you know, we have, I'm going to back up a little bit. The cause of this is usually in a patient with bed rest. and most hospital patients are pretty much confined to the bed. Especially these days, we see sicker and sicker patients that are in the hospital and are more confined to a bedridden state. So those are the patients that are the most susceptible to developing DVT or PE. And so the biggest thing is getting patients up and moving them around and getting them out of bed as quickly as possible, and making the patient aware and the family aware to get these patients up, moving around, and being as mobile as possible. Now, obviously, not every patient in the hospital is going to be able to do that, so we have to take measures with certain types of blood thinners or medications, and possibly some stockings on the legs, compressing the veins, some actual pumps that are air pumps that fit over the calves of the muscle that squeeze in and out to mimic the muscle constriction of walking and things like that. So I think for the biggest thing is the awareness of the potential of a DVT, and the prevention is one of the key aspects of the topic.
Sure. I mean, you have covered and actually went on to suggest that clearly, of course, the best of the goals for any disease is prevention, but unfortunately, in spite of the best efforts by all the medical community, you still end up seeing a great deal of patients in the hospital and outside of the hospital. On that token, I want to start off this discussion by saying, by asking Fernando as to who are the patients, who are the subset of people out there in the community that are at high risk for forming the so-called venous thromboembolism, which will include primarily deep vein thrombosis and the consequences of deep vein thrombosis.
Well, there's several groups, and you have to take into account a bunch of factors in there. And you've all mentioned most of them, post-surgical patients that have had any types of surgeries. Again, most commonly in hip and knee replacements, because in those patients they have to do modification of the bone structure. These pieces of the bone structure can go in to the bloodstream and can cause problems. Now, notice we were talking about clots, and I just mentioned bone strictures that could go in from these things. There are several things that can cause a pulmonary embolism, for example, or a DVT. The DVT is mostly a clot, but the pulmonary embolism can be part of a venous clot flying off into the lungs. It can be fat from a fracture or from a surgery. It can be part of a tumor in there. It can also be air bubbles. So those are the four big factors that can cause these things. Now, at risk, one of the things we already mentioned is prolonged immobility. Whether it's bed rest after a surgery, or you had a heart attack, or you had a fracture, or you had a serious illness, somebody that's septic, like we've had many times in the ICU that have sat there for weeks on end while we're trying to get them off the ventilators, people that have had problems with the ventilators, those people are at risk. People that are in long journeys, that take long trips, flights to India, flights to Europe, flights across the country, driving long distances, 4, 5, 6, 7 hours.
Truck drivers.
Truck drivers, specifically. And truck drivers, for more reasons than one, you have to include smoking, they're obese. I'm going to hit the cigarette, you know that. They're obese, they probably have high blood pressure or other conditions, and all these factors cause more problems there. Yeah, it makes this big storm. Patients that are older, again, they have a higher risk of having these clots form. They may have venous insufficiency. The valves and the veins don't work too well, so they get pooling, they get varicose veins, and they get into trouble in that way. They also can dehydrate. Now that we're coming into the summer, that we're going to work outside and you have to hydrate yourself. If you dehydrate, it means the blood concentrates. The cellular structures within the bloodstream can now come in contact more often and can form clumps, just like a clump of grapes. And that's the start of a clot. You can have people that have medical problems, like we said, cancers, joint replacement surgery, heart disease. Family history. This is an important one, not so much for the older folks, but for people that have recurrent clots, where you don't know where this is coming from. Now we have to start searching in the family to see if they have family members with clots in the legs, pulmonary emboli, etc. Medical conditions we went over: lifestyle, smoking, obesity, supplemental estrogen, women that smoke, that use
Birth
birth
control
control pills,
Absolutely.
high risk. If they're obese, they smoke, and they use birth control pills, we're in trouble.
Yeah, indeed, the list, as we talked about, practically everybody that gets admitted into the hospital due to some disability or the other, be it if they have a crushing bone injury, in addition to the lengthy laundry list of patients you discussed about, anybody that checks into a hospital and has had a motor vehicle accident and had a bad injury, or is otherwise had prolonged immobilization, even if they're young and otherwise healthy, including the orthopedic surgeries, the knee and hips, of course, are the top on the list.
Correct.
But certain types of cancers, as you elaborated. Among the other younger subgroups, also younger patients who in the peripartum, pregnant people, and especially in the peripartum period, means after the delivery, they tend to have a higher incidence, somewhere upwards of postpartum, 4.3% of the people are susceptible for venous thromboembolism, and and the deep vein thrombosis, also the incidence of DVT, and that can also lead to PE, but somehow surprisingly they seem to be a little more protected from massive pulmonary embolism in peripartum venous thromboembolism. But so there is clearly this has to be in a young woman. We have all seen this peripartum period, sudden shortness of breath. Immediately the red flags go up, and this is, otherwise you don't think of this. You think about entities like peripartum cardiomyopathy, where people can have the sequela, and this can be repeated also where the heart fails and markedly weakens and causes shortness of breath. But if it happens all of a sudden and hits a young patient in the peripartum period, flags go up for us all over the place, and immediately we jump and try to prevent this. And so we had to maintain a very high degree of high index of suspicion coming to diagnosing deep vein thrombosis. And I think the imaging modalities and the whole the education over a period of time, and the data has shown that any unexplained cause of shortness of breath in the hospital, we have to immediately start thinking about deep vein thrombosis, which in turn leads to this so-called PE, wherein a clot breaks loose and goes to the lungs. So things have come to that state right now. So let us back off here and again talk about, now that we talked about all the risk factors, we probably didn't cover all of them, but we covered a good bit of them. But let us then talk about how do these deep vein thrombosis, what are the clinical manifestations of deep vein thrombosis in a patient? What do they experience when they come in? How do you diagnose a patient with venous thromboembolism?
The DVT is again one of it's sometimes difficult to diagnose because they're not always there, and it's something that's transient or mobile. What a DVT or deep vein thrombosis is, it's actually a long linear blood clot that is in the vein in the leg, and it can be sometimes just below the knee, or it can be from below the knee all the way up, or it can be in the larger veins that are up more in the pelvis region. And these are just, as Dr. Arzolo was referring to, it's like a clump of grapes, but the blood just keeps sticking and sticking, and then before long the whole vein is just filled with a gelatinous or jello-like consistency.